Starting Point Coaching and Consulting presents Kairos Conversations, Connecting with Quality, the podcast. Kairos is Greek for the right time, the right season, the right opportunity. This podcast features healthcare quality professionals who share their journeys, their advice, their struggles, how they made that transition into a new and exciting role. My heart's desire is that you find this podcast to be inspirational to you as you make your own journey. Don't forget to share this podcast with your colleagues and friends and rate us on whichever podcast platform you listen to. Thank you for being here. Thank you so much for tuning in today. Today, I am joined by my next guest, Dana Strauss. Thank you so much for being here, Dana.
Thanks for having me.
I am super excited to talk to you because what you offer the world brings so much value, and we're going to talk a lot about value-based care and what that is and why people should care. And so I think this is going to be such a powerful episode for the audience. But first, let's start by introducing yourself to the audience.
Oh, I'm glad to do that. So my name is Dana Strauss. I have a long background in physical therapy. And after about 15 years into my career, I actually was introduced to the concept of population health management and alternative payment models. And I began kind of this journey towards, value-based care sort of being this, what I'll call an end point. I began this journey in working on transitions of care as a clinical liaison and realized that a lot of things weren't making sense. And I wasn't sure exactly why that was until I began to dig. And what came to the surface was that the incentives for managing patients, the best way we should be managing them for high quality care, safe care, and good outcomes was not aligned with how different silos of care were being paid. And it just so happened that at that same time, we had the first accountable care organizations forming. And an accountable care organization is a group of physicians, hospitals, pretty much any type of provider that come together and agree to work on prioritizing the quality of care provided and improving the value of care for patients within a population. So the first ACOs began, and I am from Northern New Jersey. And the hospital that I was working for decided to start a population health department and begin a journey towards improving patient safety, improving quality of care, and improving outcomes of care. And I had a chance to then take what I was seeing and experiencing in these silos and this disconnected care and have a way and a new structure for coming up with good solutions by developing programs within this population health department. And so I began developing and managing along with a team of other leaders, began programs first that worked on transitions of care between the hospital and skilled nursing facilities and inpatient rehab facilities, working with patients and their families, working with the skilled nursing facilities, and working with our hospitalist and geriatric teams, palliative care teams. And it was really eye-opening to see how much could be improved when we started actually looking at what was best for patients and not what was best for one site of care's own billing and what they were concerned about, really truly taking down silos of care and saying, what's best for patients? How can we figure out how to make this journey a patient is going through, particularly our most complex sick patients? How can we take this journey and make it safer, improve the quality of care, improve the patient's ability to get back home when possible safely, and connect those patients back to their care in the community once they're home. So after that, I ended up going to a startup company actually that was working on one of the programs in in population health management, specifically focused on episodes of care. And, I was able to do, and in a startup, able to do a tremendous amount in terms of learning and providing strategy. We had to become an expert in public policy around these new payment models, working directly with our clients who were in these programs that we were helping to manage. And a lot of what these I'm going to call them about 5 years, did for me was put me in a place where I had to become an expert in the public policy around these new payment models. And that's really what when we say the word value-based care is really a structure and a way of reimbursing providers based upon the quality of care they provide, meaning that quality of care is provided at the lowest cost possible to achieve the best outcomes possible. And different types of payment models all can fall under this bucket. I'll call it a value-based care. It takes into account patient safety, quality of care, and maybe most importantly, as a clinician, evidence-based care. It's really based on providing the best care at the best place at the best time for the patient and not for the provider themselves that's giving the care. We're worried about the patients themselves.
I appreciate that explanation because I think that a lot of people don't understand what it is. I mean, value-based care is a buzzword that we hear in the news and on social, but really understanding what it is. I want to back up a little bit and ask you, as a physical therapist, how did you get that initial voice at the table in these kind of roles in policy and value-based care, your initial roles? How did you get a seat at a table as a practicing physical therapist?
I get that question quite a bit. And I would first say it's a journey. It's not a light switch on and off. It was really exploring the things that as a clinician, I felt didn't make sense, really didn't make sense for patients, didn't make sense for the kinds of skilled care that a physical therapist should be providing. And I guess I'll go back all the way, imagine, to 2002. This began. So 2002, way before the Affordable Care Act and anybody was talking about population health. I had just left working in an inpatient rehab facility, which was my first job out of college and grad school. And I came to work in home health. And when I got to home health, I started with a manager who was also brand new to the home health agency. And we started having some quick conversations about what the opportunities were in home health to really make a difference for patients. This manager cared a lot about that too. And I kind of pulled out of my hat. One of the things that really bothered me working in inpatient rehab was seeing these very high level total joint replacement patients, lower extremity joint replacement patients, coming in to an inpatient rehab facility. So this is at a hospital setting, 3 hours a day of therapy, right? Physical therapists are often OTs, STs, well-versed in what inpatient rehab is or acute rehab. And these total joint replacement patients not needing to be there, walking with a cane within a few days, many of them, and just it not making sense, feeling that there were a large number of those patients that could come right home and receive home health rather than receiving acute care, acute rehab. And when I started exploring the cost difference, there was this complete alignment between this incredibly high spend in a acute rehab facility, ballpark around $17,000. That varies depending on region and it changes over time, but around $17,000 versus a stay in home health where the patient's in their own living environment, right, is back with their family. All of the reasons we know it's good to be home if you can. And that stay was along the lines of $2,000 to $3,000.
Huge difference.
it just was mind blowing. It was mind blowing to me that this was happening and there was no incentive to identify at the hospital or before the surgery which patients would more likely benefit from an inpatient site of care as a post-acute setting versus a home health setting. And this goes back 10 years before anybody was thinking about these things. So we decided, well, we're going to try to start a program. We're going to go work with our orthopedic surgeons and, pitch this idea that we have a way within our own health system, our own home health agency. We have a way of serving these patients where we don't have to send them to inpatient rehab, and that our hypothesis was there were going to be patients that would want to do that, and that there were ways to identify the right patients. And so it really ended up quite successful. Even back then, we started essentially working with, it was more managed care patients because the incentives of the insurance company were such that, it's beneficial for them, of course, to send a patient home. Whereas in Medicare fee for service, you're not interacting with the insurance company at all, right? So we would have patients or commercial patients, let's say, who had a payer that was really incentivized to consider the different options. And when a patient would, let's say to their doctor, is there any way I can go home? I don't want to go to for inpatient rehab. The doctor then had a way to say, oh, well, we do have this program where, our own home health agency can send a physical therapist and a nurse the next day, and we can see you in your home. And so little by little, as patients experience this, and we're giving the feedback back to their surgeons that this was a great experience, and we watched their recovery be what we hypothesized it would be, which was excellent, right? We as a home health agency were making visits 4 to 5, sometimes 6 times a week in the first week, and just tapering down for a few weeks before sending them to outpatient therapy. It worked really well. Like, why wouldn't it, right? So over time, as this became more the norm, we had hospitals in New York City recognizing that they could send their patients in New Jersey to our home health agency to receive this home health post-acute care. This is value-based care, right? This is value-based care outside of certain payment structure that's incentivizing it. We were providing the highest quality care with the best patient experience in the lowest cost setting and achieving the best outcomes before there was any reason to do so. And I guess knowing that was possible opened my eyes up to where else can we find these types of opportunities within the healthcare continuum. And why can I get someone to care that this is a possible, direction we can go in terms of the healthcare experience for our benefit, our patients, our members, our beneficiaries.
Awesome. So if you started talking a little bit about fee for service, can you go into a little bit what the different models of care are and how they're different?
Sure. Yeah. So a fee for service means exactly what it sounds like. It means you go see a provider, that could be a physician, a physical therapist, a dentist, a chiropractor, an OT. You go to your appointment, your insurance company pays the bill, and that's where it ends, right? Your provider is incentivized to provide that care, and they're not incentivized because they're not paid past that visit to provide any kind of follow-up, right? It is a fee for that service. That is the way our payment structure in the United States has been for decades. It's what every one of us is familiar with. I go to the doctor, my insurance pays, I pay a copay often, and I go home.
And then that provider, if they wanted to give you let's say you had labs done at that visit, and they wanted to tell you your labs, it would benefit them to bring you back in for an appointment just to tell you the results of those labs.
That's a very good, simple example, right? In order to talk about anything past that visit, right, it would be in their best interest to keep bringing you back in to the office. But juxtapose that to prevention, right? Or annual visits where you can have, make sure that you've had, let's say, your mammography, your colonoscopy done. Are you going to the dentist? Because we know how important that is. All of the things that should be happening for the best longitudinal long-term outcomes for, let's say, a physician's, or if we just talk physicians, for a physician's patients. In fee for service, there's no reason for a physician to reach out to their patients and have them come into the office to go through all of these preventative screenings, to make sure they have set up their preventative testing, right? None of those things in fee for service have a reason for a provider to do them. That in and of itself is the distinct difference between fee for vet service system and the opposite, which is a fee for value, we call it, or a value-based system, where there are reasons, monetary reasons, why it benefits the provider to make sure you're getting all of your preventative screenings, that you're catching anything that's happening that's negative, any early disease that might be developing. You're catching it at the earliest point possible so that your patients, the ones that you take care of, that you're responsible for as a physician, let's say, that your patients are having the best, right, the best health aligned with the lowest cost overall care by catching diseases early. Let's say we can treat them early and we avoid a lot of that high cost spend down the line, right? That might not be in the office of the provider themselves, but certainly is a cost to the whole healthcare system.
So is value-based care the same as pay for performance?
Pay for performance is if you think of it, value-based care as a continuum. So pay for performance is kind of the earliest type or the first step in value-based care, where you're doing certain things, you're like checking certain boxes, things like getting preventative screenings done, right? That having those things done, that's pay for performance. The provider's performing. The furthest end, the most advanced value-based care is when the provider group, or the organization themselves is responsible for all of the dollars that is required to care for a patient over the course of a year. And so there's this big spectrum where providers may start out in you're incentivizing, completing certain quality measures, whereas the far end of the spectrum is you are putting those providers at complete responsibility for all of the dollars spent over the course of a year, multi-years, decades for any set of a patient population. It's a big continuum.
So I like to think about this example, and please correct me if I'm wrong in my thinking. But I think about the orthopedic surgeon, because I used to work a lot in orthopedics. The orthopedic surgeon who schedules his patient for knee surgery, as an example, for a total knee replacement, who is responsible for the pre-op visit, the surgery, the post-op visit, the therapy, whether the patient goes to outpatient home health or inpatient rehab. And all of that, the outcome of that is the responsibility of that orthopedic surgeon. And so it's to their benefit, his or her benefit, to find the best use of the dollars for that patient in determining what type of therapy, if any, they may get post-operatively.
That's a great example. And that is an episode-based model. And so I'm really glad you brought that example up. So there are value-based care models that are longitudinal models. So that means it's all of the care across a time period. Generally, we look year after year. Episodic models are models of payment and of care that incentivize outcomes of a particular specific episode. And so one of the really well-known value-based care programs is the Comprehensive Care for Joint Replacement program. And in that model, for those who are not familiar, the Center for Medicare and Medicaid Services establishes what they call a target price for a 90-day episode that starts with the day of surgery and ends 90 days later. And they determine these target prices based on a number of factors and things like historical spend in that region, the efficiency of that provider in the past, the risk profile of each individual patient. There's a host of factors that go into CMS, Center for Medicare and Medicaid, determining what that total episode should cost. And in that, we call it the CJR program, Comprehensive Care for Joint Replacement. In that program, the incentive is given to the surgeon themselves, right? And we say, or what the payer, CMS, is saying is, we expect that for Mr. Smith, it should cost approximately, I'm making up a number, $30,000 for every bit of spend over 90 days. And so we are going to incentivize you as the surgeon to develop the best trajectory of care that you can, knowing this patient. As you know, so what does that entail? Some of the basics are things like, a patient has a very high BMI. Is it more beneficial to work on, let's say, the patient losing 10% of their body weight before surgery because of the risks associated with performing that joint replacement on someone morbidly obese? Or let's say their hemoglobin A1C is 11. It is not ideal to do a major surgery on someone in most cases when their hemoglobin A1C is very high because the risk of complications goes up. So the first thing we hope that a surgeon in this program will do is look at the things that could make the surgery itself turn out poorly. High blood pressure, very high body weight, very high A1C. And we're hoping that the surgeon takes those things into consideration and helps to make the best decision about timing based on factors that may be able to be controlled by working on those other factors. So maybe working with the primary care doc. And another thing that a surgeon can do is developing a team that can help work with that patient to determine how, ideally, after the surgery, we bring them home and get physical therapy and home health. Doesn't this sound a lot like the program that we developed in 2002, right?
Mm-hmm.
Same idea. It's just now there's this great incentive that let's say the surgeon and their team, whatever that looks like, can look a lot of different ways. They have set up what they believe to be the best plan for this patient surgery and post-op. And they go through those 90 days and complications were low or none. The patient went home, right? No infection. The patient's total experience over those 90 days was as positive as it could be. And so it's not a but or an or, it's an and the spend was less than the predicted spend based on all those factors we talked about. So let's say that $30,000 predicted spend over 90 days was $25,000. That's $5,000 difference. And in that comprehensive care for joint replacement program, that difference is a dollar amount that is shared with that surgeon and hopefully, right, the whole practice or the group that's working with that surgeon to help reduce that spend. You've taken that incentive and turned it into the best outcome for the patient, and you've saved dollars based on the predicted spend versus the actual spend. That's really how an episode of care, which is a type of value-based care, that's how it works. And so as you as a quality expert, right, whose career is focused on quality and outcomes, you can see, I'm sure, this complete alignment between value-based care programs, and in this example, an episodic program, a complete alignment between these programs and quality of care.
Oh, absolutely. So in this case, the $30,000 in this example, does that physician get the whole 30 regardless of if they spend 25 or if they spend 35, they're getting 30?
Oh, I'm glad you clarified that. So the 30,000 is the spend for all the care. So if that patient went, let's say they went to a skilled nursing facility and they went to home health, all of those providers, all of the care is paid for normally in the CJR model. So the patient goes to the hospital gets paid, the surgeon gets paid, the anesthesiologist gets paid, post-acute care gets paid. All of the spend during that time is part of that $30,000 total spend, total cost of care spend. If certain factors help reduce that spend, such as going to home health and having a good outcome versus going to a skilled nursing facility, right? Or lowering the chance of a readmission or a complication because of comorbidities a patient may have, you're reducing the likelihood that that $30,000 total spend will be necessary. So when there's a difference, it's the difference that's given to the surgeon, or to percentage of that difference. So, but essentially, a large majority of that up to a cap amount. So they don't allow an unlimited amount of money to be given back. But there is a large amount that a surgeon can earn back if the total episodic spend is reduced. So it's not that in the CJR program, it's not that the hospital's paid differently or the post-acutes are paid differently. It's if that total spend by everybody that's billing over 90 days ends up being less than what was predicted by CMS. The surgeon and the group that's supporting the surgeon, if you think of it that way, the surgeon is getting the dollars saved back. So if the quality is good and the cost was reduced through the 90 days, everybody that's caring for the patient, the incentive was put on the surgeon. But along with that incentive to earn back some of that difference between what was expected, it goes the other way also. So if the outcome and the spend ended up higher than predicted, the surgeon is responsible for that overspend. So you can see the incentive in this type of a model is both upside and downside, right? So if you're participating in a model, an episodic model like this, you want the aggregate, your goal is the aggregate of your patients. You want there to be more patients that have a higher quality and lower cost than expected versus the patients that have a higher cost than expected and lower quality. So it's not patient by patient. We look at it over, let's say there's 300 patients in the year. Well, if 200 of them did better than expected, at the end, when we look back at the period of time that the provider was seeing those patients, the upside, the patients that did better than expected, there'll be a net positive that is returned back to the surgeon. Not every patient is going to end up having better than expected outcomes. You're trying to set the episode up as best as possible so that as many patients as possible do better than expected. Hi, friends. I have found that when clinicians decide that it's time to leave the bedside, often it's like throwing darts at a board. They just want out and will take almost anything just to move into a non-clinical role. I have always recommended taking the time to really identify your strengths, passions, and skills, and what will fuel you so that your next role is your best role. I couldn't find a tool specifically for healthcare professionals that would provide the depth needed to get a really good career evaluation. Until now. I am so happy to recommend the Stream Ahead assessment created by Career Clinic.
It's the profile that I wish I had created first. Stream Ahead is thorough, comprehensive, and frankly spot on. And yes, I have personally taken it myself. I'll share the link in the show notes section of this podcast. You can thank me later. So there's a huge benefit, Dana, in deciding what is best for each patient to give them the best outcome, as opposed to sending everyone through the exact same model. So everyone goes to inpatient rehab, in the example that you used earlier. There's more benefit to say, Miss Jones would do better in inpatient rehab, but these other non-patients can go home.
That's 100% accurate. This is individualized care, even when it comes to the hospital itself, right? So the hospital in something like a total joint replacement, most of them in Medicare are still done in the hospital, although they've removed that requirement, that site requirement for total joints. Many are still done in the hospital. So you can imagine if the incentive for the surgeon and their team is to reduce the total spend, then the incentive is also there for the hospital to work with the hospital, for example, to develop a really good mobility program so that patients are getting up as quickly as possible after surgery, right? Another great example of the kinds of things that are done in that model, the surgeons working with the anesthesiologist to change the type of block they're doing. So if they're doing a femoral block all the time, it's just what they've always done, but the femoral block shuts off the quads. What we hope when we're managing these programs and working with the surgeon in the hospital, an example is, well, we'd much prefer an adductor block, because when we don't shut the quads, we can get patients up that much faster and safer, right? Less likely to buckle, feeling more confident. Another really good example that is often best practice in CJR is to say, well, we know that post-op medications we usually give, as an example, morphine, IV, but what we know is a very effective painkiller, but costs a little bit more for the hospital, is IV Tylenol, right? IV Tylenol might be $8 or $9 a bag versus morphine is 50 cents a bag. But IV Tylenol is extraordinarily effective at reducing pain. When you remove the morphine, now you're removing all of those other complicating factors like nausea and constipation and drowsiness, right? So all of these things increase the likelihood that that patient gets up early, that they feel good from the beginning, and that we can follow a plan to hopefully get them home and begin their rehab journey in their own home setting. Does that make sense, right?
Total sense. So I hope the audience is getting as much out of this as I am, because I am learning a lot through this. So this model, is it specific to Medicare, or does it apply to the commercial insurers as well?
So that's another great question, and relates back to public policy. So the comprehensive care for joint replacement was developed by the Center for Medicare and Medicaid, which is, right, that's your straight Medicare, traditional Medicare patients. But what is driven by the Center for Medicare and Medicaid, right? They pay for, between Medicare and Medicaid, approximately 50% of all care is paid for by the government through those programs. They tend to try to push innovation at the government level through these programs. When they first began this comprehensive care for joint replacement, it was available everywhere, right? You could participate in this in lots of parts of the country. It has been so successful that it is now a mandatory model in certain regions of the country. And that model is now kind of become like the standard practice. So what happens is other payers work with providers to develop the same types of programs for them as the payer. So let's say I'm Blue Cross Blue Shield, right? And I also pay for surgeries by let's say Dr. Smith, the orthopedic surgeon. Dr. Smith is participating in CJR, paid for by the government, by Medicare. I, as Blue Cross Blue Shield, can come up with the same type of program, but for the Blue Cross Blue Shield patients. Mm-hmm. So giving the same types of incentives, creating a similar model for any payer can be done by any provider, right? You can have commercial insurance, do the same type of model, Medicare Advantage. Really, any model that CMS creates can be mimicked if there's interest by other payers. But the government models, the Medicare, they can push it from the public policy perspective. They're creating new programs through regulations and policy that allow for these alternative ways of reimbursing providers. And that's what I get so excited about when it comes to value-based care and policy, while they're so integrally connected. Public policy flexibilities and changes and modifying regulations to allow these different types of incentives, creating incentives through payment, help to drive better quality, better outcomes at a lower cost.
So for the person who's listening to this episode who may be a bedside provider, whether they're a therapist or not, what advice would you give them into getting into this space, and why should they care about this?
Some of this depends on the type of provider that you are. I'll start with as a physician, because a lot of the incentives that have been created thus far have been done at the physician level. As a physician, I like to think like things that make sense. What we've proven over the course of this decade through various models, the CJR being a really concrete, substantial, like heavily participated model, what we've proven is that when we change the incentives by the way we pay providers, we get a reduction in spend and we get a better quality care, and the patients are the ones that benefit. So when things end up making so much sense on every level, the way I like to think of it is there's no going back. And that's a theory that it's not just my own, feeling. There's a large building understanding of this in the public policy space, insurer space, right? So all kinds of payers. This is the way we're going, and we know we're going this way because it's working. Is it still being iterated upon? Is every model, every payment structure created going to work in all circumstances? Does it need to be refined? Absolutely. This is still very new, right? But it works. We know it works. So if I'm a physician, what I say to physicians is, you must understand this yesterday. If you're not yet well-versed as a physician in what an alternative payment model looks like, how it works, you need to prioritize that as a professional goal, because without knowing the basics, at least the basics, and becoming versed, you will miss those opportunities to collaborate with other providers who are in this space. You will miss the opportunity to be in high quality networks where those participating in those networks only want to work with other high value providers because it impacts their own ability to be successful, right? So it depends. If you're a primary care provider, it's more of the longitudinal models you want to participate in. And if you're a specialist, it tends to be more episodic types of models. And just as a specialist, recognizing that primary care providers in models want to work with and develop partnerships with specialists that are providing the highest value care. Same basics, right? Which specialists do the best thing for each individual patient and take into consideration the full picture. So that looks like a cardiologist who talks to the primary care doc who referred the patient so that they understand what's led up to this referral. And it looks like an orthopedic surgeon not automatically doing an MRI because a patient asks for it, right? But does one because they first evaluate the patient and determine, based on evidence-based practice, that that's the next best thing to do, right? So for specialists and primary care docs, it is yesterday is the time to understand value-based care. When it comes to physical occupational speech therapists, if I touch on them next, I have really found a lot of uphill battle. It's starting to improve, but I have had an uphill battle in talking to therapists about this, because I think mainly because of the way in Medicare Part A, so that's right, hospital-based insurance, in Medicare Part A, physical therapists don't provide a service and then bill for a service. The site of care, if it's the hospital or if it's the skilled nursing facility, that site of care is paid, and then they're paying a salary to the therapist, the therapist, the PTOTST. They're providing a salary, and that salary is just based on them doing the job based on the job description of that site of care. It's not based on that therapist making the decisions for how they're providing care or what recommendations they're making based on what's best for that patient, let's say 3 months from now. Or in the hospital, working with hospital-based PTs, OTs, and STs, as I, in those, in the setting that I was working with the therapists themselves to say, so when we're going to make a recommendation about the next site of care, we need to understand what this patient has been functioning like truly prior to them being in the hospital for any reason, and then establishing what makes the most sense for that patient next. And so a good example of that is a patient who's, let's say they're in the hospital for a UTI, they're walking with a walker and they need some assistance. Well, if that patient was mostly functioning that way before, is there going to really be a benefit to that patient going to a skilled nursing facility to sit in a wheelchair 22 hours a day and get a little bit of therapy? Or is it best to send that patient to their home setting, make sure that who the person's with is trained well on how to assist them as they're continuing to gain their strength back, and sending home health in? And by the way, making sure home health goes the next day so that we can capture anything that's of any concern right when they get home. Does that make sense? And in the outpatient setting is the place where PTs, OTs, and STs are billing for their own services under Medicare Part B, or the physician fee schedule payment, right? If you're talking about Medicare, any insurance, you're billing directly for care as an outpatient provider. But that gives you the same sort of conundrum that we have when patients go see their physician. If you're an outpatient therapist, the more often you can see a patient, and for the longest time you can keep a patient coming in, that means more money in your pocket. So what incentive is there for an outpatient therapist working in fee-for-service? What incentive is there to come up with what's absolutely best for the patient, to help themselves, right? To help themselves at home, to do as much as they can on their own, and to identify the best frequency of actually coming into the clinic that's necessary, right? Not what's best for the therapist to be able to bill. And unfortunately, we have, as a country, we've decided to pay for care. We have created these perverse incentives for all providers to try to drive volume of care, like a volume-based, fee-based, volume-based type of practice, versus saying, well, what's really best for this patient? Do they need to be here 3 times a week for 9 weeks? Like, does that just because a prescription from a doctor says so, or because it's best for the amount that I can bill? Is that what's best for patients? Not saying that every therapist does this, but generally speaking, if this is the way as a therapist you're reimbursed, why would you try to come up with a different way of managing patients that's less money in your pocket, right?
Right. I mean, that's the conundrum right there, right? Is you want to do what's right for the patient, but at the end of the day, you got to pay your bills And if you are a private owned practice as a therapist, in this example, then you've got to keep the door to your practice open. So, then there's huge incentives for volume if you're not a cash-based service. So you make some very good points. So now that you're completely away from the bedside, what do you do on a day-to-day basis? Like, what does your day look like?
Well, so at this point in my career, I work on a public policy team for a Fortune 10 company. And what I do on a public policy team is I function as a subject matter expert and policy expert in value based care. So I have to be well versed and an expert in the various models of care. I focus on Medicare models and Medicare Advantage models, on models that are being used, that are being developed, and that are being refined, and help the businesses for this organization, help the businesses understand those models, and help to develop the ideal recommendations for how those models could be potentially improved, how new models may be beneficial for sets of populations. So I'm responsible for knowing those models, for responding back when there's changes made to models, for making sure that businesses understand these different models of care, making sure clients are understand the models and understand the things that will help them to be successful in these models of care. And so kind of public policy means the rules, the regulations, the laws that govern anything that's controlled or directed by the government. So public policy in healthcare delivery is really thinking about ways and value, specifically to value-based care. It's looking at ways that care can be provided differently through different models of payment and different incentives for payment.
So for a person who says, this sounds great, I want to work in this space, what skills do they need? How do they get started?
So, and I would say that this space has a lot of room for clinicians who are interested in it. And I say that because the public policy space has overall very few clinicians. It's generally those who work in public policy are very often attorneys and public policy. They have a master's in public policy, for example. Many have worked in the federal government or state governments before. The perspective that a clinician has to public policy is exactly what you would imagine. We know the good and the bad and what opportunities actually look like in the clinical care space when you're working with a patient, you're working with other providers. But the skills you need to be successful and to enter into the public policy space, I'm going to say from the value-based care perspective, are to develop an expertise in something, right, in healthcare that is driven by regulations and laws. And so healthcare is highly regulated. It's one of the most regulated parts of any sector, right? Healthcare is a heavily regulated business. So understanding the basic payment regulations of all the different sites of care, right? Understanding what value-based care programs, how they function, right? Understanding how providers get involved in them. How are you successful in them? Like learning about them as they're being developed and rolled out, learning about them, being able to speak about them. By knowing those things, you can first bring opportunities to wherever you're working in whatever capacity, because so few people, so few professionals in the clinical setting understand these models well. It's not that they're that complicated at a high level. It's that to dive into them, no degree is going to help you understand them. It's just learning about them, reading, I listened to tons of webinars in the beginning, for example. I did a lot of reading, understanding them at a deep level and connecting the opportunities in the clinical setting to the value-based setting, to the payment and regulation setting. That sets you apart. And honestly, I would say even outside of the public policy space, value-based care is still so new that demystifying it, realizing it just means the best quality of care at the best price, right? At the best cost, realizing it's not this magical, mystical thing. It's very practical. Being able to speak about it and see the opportunities wherever you work, right? How to get involved in those early opportunities can open up so many different options for career directions. Public policy is just one of them. And that could be at the state level or the federal level, frankly.
This is huge. I hope people are really diving into this information that you're sharing. And I do want to ask, if people want more information or want to connect with you, how do they do that?
Definitely subscribe to my free newsletter. It's called Timeless Autonomy. And in that newsletter, I talk about healthcare innovation, specifically focused on value-based care, and it's directed at healthcare delivery professionals and health tech professionals. And please also subscribe to my LinkedIn. I try to stay relatively active on there. And I'm considering developing some educational programs for clinicians who are interested in learning more about things like public policy and about value-based care. So that's in the works, but the way to connect with me most easily is subscribe to my newsletter. You respond right back to my newsletter via email, and now you're speaking directly to me. And I answer every email I get, and I'm happy to connect with anyone who's interested in hearing more about this.
Well, I will link both of these in the show notes so that people can click on the link directly. So that's timelessautonomy.com. But again, I'll put it in the show notes. And then I'll also link to Dana's LinkedIn page so that you can connect with her there. Dana, this has been such a jam-packed episode. I have learned a lot. I'm over here writing stuff down. So I hope the audience got as much out of it as I did. Do you have any parting words for the audience?
Yeah, I do. My parting words would be, if you're a clinician interested in stepping outside of clinical care, but still having an impact on healthcare delivery, but being able to have that impact at a much larger scale, get knowledgeable about value-based care. It is still in its infant, maybe early toddler stages. There's incredible opportunity to develop expertise. And with that expertise, when something's new, comes tremendous opportunity. You can really make a big difference in healthcare and in the populations of patients that we care so much about as clinicians. If you can be still an earlier adopter and true believer in value-based care being a better way to deliver a safe, high quality, more effective, total healthcare experience for patients. I'm the biggest cheerleader there is for value-based care, not because anybody ever told me I should be, but because in the deepest parts of me, I knew this was the chance to change healthcare for the better. It isn't going to be easy, but the more clinicians involved in it, the better off everyone is going to be.
I love that. Thank you so much for being here and for sharing all of these practical tips and all of this knowledge with the audience. I really appreciate it.
Thank you for having me. I really appreciate it, Brandy.
Thank you so much for listening to the show. It would mean a lot if you would share this episode with a friend or a colleague. I would be honored to encourage them in their journey too.